Yeah, please. Good morning.
Is it possible to find out the ERO of the recursive vital type?
Yes, the planimetry of the vena contracta, you mean?
Yes.
Okay. I think I have put one case, if I remember correctly. PD, let me check a second, because
Last but one.
let me check this one. I know there is no color. Okay, I will show you on my computer. No, unfortunately, it's not. No, I don't have here.
One MR prior to this.
There
this
is
one, organic MR.
there is color. No. No, there is no color. I didn't select. Sorry, I was in my mind.
Mitral case.
What?
There was one mitral case also.
Okay.
It's mitral stenosis.
Yeah, but it was mitral stenosis. Mitral stenosis. There is the color. No. No, I don't think there is the color. No, unfortunately, I don't have, but I will show you on from my computer. Okay, let us start. Do you have the cases on your computer?
Yes.
Okay. So to select the cases, you can do this in the last name, just type PD. And this is the... We can start from the PD FMR TOE. If you are in trouble with any of the steps, just raise your hand and we will help. And then you have just one data set, so you can double click on it, and this is the data set. How confident are you with this software package, EcoPack? Who has never used the EcoPack before? Oh gosh. Okay. So I will go step by step in order to show you how to manage it. So first of all, look at the right side of the screen. You have some buttons. The first one, stop, will allow you to stop the movie, and when you click on that, it opens on the right side this frame with the two arrows, left and right, that will allow you to select the proper frame. The button below is the 2D gain, and allows you to reduce or increase the gain, of course. The 4D gain is one dedicated exclusively to the 4D dataset, and it's a sort of compression of the data. Layout, it's a very important button, and controls the way the images are displayed on your screen. This is the acquisition window, where you have the acquisition view, the one that you have obtained with your probe, and the orthogonal one showing you the depth in order to check that everything is into the data set. So we have the entire mitral valve in the, let me say, apical, the long axis view. Here is the aorta, and this is the 90 degrees view. And then on the right, you have the volume rendered. If I press this layout once, sorry, it changes. And now we have 3 two-dimensional views. Again, the acquisition one that it cannot be changed. And by default, you will have one view that is at 60 degrees from the acquisition one, and one view that is at 120 degrees. This is by default, but their position can be changed, and I will show you how to do that if you need. One important point is the relationship between the color of the quad, yellow, white, and green, and the cutting lines. You see that the yellow is at 0 degrees, the white is the one at 60 degrees, and the other one is at 120. Clicking once again the layout, it changes again, and now the only thing that you have on your screen is the volume rendered images. So I am not making anything on the images, I am just changing the way these data are displayed on the computer. In any case, if you are lost and you have made a complete disaster on your data set, you can always press 4D home, and this will bring to the original acquisition. Okay? Let us go back on this presentation. This is how we have acquired. Now, if you wanted to understand 4D echocardiography, you have to change your way of looking at the images. With the 2D echocardiography, we have something that has been acquired and cannot be changed. We can just look at it. If it's been acquired in the wrong way, we will drive wrong conclusions. With the 4D echo, it's completely different. We don't look at one slice from outside. We are inside of the data set. Imagine that the data set is this room. And what I see in this room depends where I am in the room and the direction I am looking at. So if I am standing here and looking in this direction, I see perfectly the class, but I cannot see the slides because they are in my way. They are in the data set, but I cannot see. So to see the slices, I have just to turn myself, changing the direction of my view despite being in the same place. Now I can see perfectly the screen, but I cannot see the class anymore. And if I wanted to look at the screen of the echo machine, not only I have to change my direction, but I have to move into the data set. I am navigating the data set now, coming here, and then turning again. Now I cannot see the screen, I cannot see the class, but I have a perfect look at the screen. Have you understood the concept? We can obtain anything, but the structure of interest should be into the data set. And this is our main concern when we acquire, that what we wanted to examine is in the data set. Doesn't matter the approach we use, transthoracic, transesophageal, subcostal, apical. The important point is that the structure is inside of the data set. And this is why we are so concerned to use these multi-slice or multi-view to ensure that the entire structure, in this case the mitral valve, and a piece of the surrounding structure, that is the aorta, over here and over here, are inside of the data set. Okay. Then we can start to manipulate the data set. The position where we are in the room is the orange line. The direction we are looking at is the yellow arrow. So now I am sitting into the atrium, quite back. I am looking towards the mitral valve, and so now I am looking at the valve from the atrial perspective, that is the surgical view. Yes?
My view is slightly different from yours. Where
Your view is slightly different from mine? Yes. Okay.
where did I go wrong?
No, you didn't go wrong. You have just changed your position. You are not in this direction looking in this way, but you are, oh sorry, I touched the, but you are looking in the transversal way.
Now, how do I get it right?
Yes,
I've never
now,
used
now I will come. Go back, click home in order to have the image as I am, and we will see.
click home.
Home. For the home.
Yeah.
And now you are like me. Is it okay?
Yeah. All the same. Yeah.
Perfect. So now we want first to obtain, I will show you the long way in order to, for you to understand the principle. And then we will see that there are a lot of shortcuts that can help us in working. So if this is the position I have in the data set and I wanted to go closer to the mitral valve, I have to use this translation. And if I click on the leftward arrow, I move my position. I am navigating the data set, going closer to the mitral valve. Is it true? Now I am here, but I am not in the proper position because it's not the anatomical display. To do that, I have to rotate the data set in clockwise, and I move my pointer in the volume rendered images outside of the data set, and this change the shape in a double arrowed circle. That means I can rotate counterclockwise or clockwise. If we rotate clockwise, we will have our view with the aorta at 11, 12, with the mitral valve over here. But it's not a nice view because I cannot see the posterior leaflet, and I have missed one part of the mitral annulus over here. So I have now to rotate the data set. And to rotate the data set, I will move the pointer inside of the data set. You see that it's changed the shape, has become a sort of FIFA flag. That means that if I click on the left button of the mouse and I move it towards the right, I can rotate the data set. View crop. But still is not optimized. And the reason for that is that I am too low with my point of view. You see that part of the mitral valve is going behind the line, so behind my shoulders, and I cannot see. So I have to go back a couple of steps Again, translate, back. And now I have the entire valve over here.
Sir,
Yes?
as you rotate the 4D image, the other image is not moving.
The image?
As you rotate the 4D one, the other front line is not moving. The 2D image is not moving.
No, the 2D image doesn't move. What it moves is this line. Because the 2D images are the acquisition.
How to rotate that orange line, the 2D image?
No, you cannot rotate the 2D image. This will stay always like that. If we wanted to obtain slices from this data set, we have to go to multi-slice. And then we will obtain all the slices we have. But these two cannot be changed, okay? Click on View Crop. Okay? So you will activate the cropping part. And now if you move, you will see that it will change the position. Is it true? No? Okay, I will come. Okay, if I, sorry, okay, it's here. You see that it moves?
Directly we can't move this line.
No, you cannot move the line. The line shows where you are. You cannot control the line, okay? Are you fine? Perfect. Oh. I made a mess. Okay. Everybody is here? No.
Spectral path has gone out of view.
Okay, because you use the two-click crop and you have a parallel cropping, and so you have selected from your data set only this part. You see? Your data set now is just this. If you wanted to look at the mitral valve now, you have to get rid of the parallel cropping, clicking on parallel crop, and now you have your mitral valve. Okay? Welcome. Everybody is here with me? Okay, we can move forward. Now that we have obtained, thank you, the desired view, we wanted to have a better display of the anatomy. We can use different ways. The first one, we can change the colorization or depth map. You know what it is, the depth map? As we discussed yesterday, the colors of these three data sets have nothing to do with the tissue. They are used to trick your eyes in order to give you a perception of the depth on what it is, a flat screen. This has been derived from the electronic games of the kids, the FIFA World Cup by Sony, and etc. With the shades of the color, your eyes have the perception of the depth. They use more brilliant colors for the structures that are closer to you, and the darker colors for the structures that are more away from you. We can change those maps, and if you go on the copper blue one and click with the left button, you will see that you have different choices. You can go on the copper blue 2, bronze gray, bronze blue, depth bronze, bronze, gray 2, whatever. There is no a map that is better than the other. All of them make the same work. Just choose the one that fits better with your eyes. Then we have another important button that improves the quality of the images. That is the HD Live, high definition. If we click, this is the results on your images. Much closer to the anatomical perception. You have many more details on the anatomy of the leaflets and the annulus, you see? Quite interesting, once that you have clicked on the HD Live and go back on the depth map, now the list is changed and you have other opportunities. One that is quite interesting is the anatomic. You lose the colors that may be interesting for some one of you, but you see that the anatomical details of the images are much more striking. However, if we like, we can go back on the usual one, that is the copper blue. Sorry. That is really nice. No one is better than the other. Depends on your eyes and your own preferences. There is one other option, that is this stereo vision that you can use. With the stereo vision, you have to use the glasses for the same that you use in when you go to the 3D movies like Avatar and so ever. And there you have really the depth perception of the images coming outside of the screen. There is no particular clinical advantage of using them if not to raise a wow from your fellows or your head of department. The only real advantage I have seen in patients with the multiple catheters, for example, patients who have multiple catheters in the right side heart, and there is a suspicion of endocarditis, and so we should separate those catheters and the leaflets of the tricuspid valve to see the vegetation where they are attached. The last point, just click back on the stereo vision that I wanted to show you, is the light source. We can illuminate or obscure part of the images according to our needs. Just stop the image in one point and now click on this light source and you see that there are shadows that are going around in your image. In this particular data set, it doesn't change that much, but when you are in the cath lab with all the guiding catheters, devices, or whatever, it's important to be able to cast the light from different points of view to see where the catheter are. And then we have the famous flexi slice that we have discussed yesterday. We can click, and once again Now we can change the different two-dimensional views, because now I can control the different lines, the white one that corresponds to the white quadrant, the yellow one that corresponds to the yellow quadrant, and then the green one that corresponds to this one. To change the position of those lines, I will move, I will move my pointer on the lines. If I am on the line, it becomes a sort of line with these two arrows. That means I can translate the line left or right. If I go to the edge of the line, it becomes a double arrowed circle. That means I can change, I can rotate clockwise or counterclockwise. You see here that if I rotate one line, the other one goes together. This, I don't know why they have made by default this, because it's really annoying. To make the lines, to control the lines independently, I have to click on these lock slices. If I click on it, now the two slices can be controlled independently. So imagine that I wanted to assess the size of the mitral annulus, and as we have discussed yesterday, I have to have the longitudinal line in the center of the hole, perpendicular to the direction of the hole, in the white and in the yellow, like this way. And once I have done that, I can control the green one that will be perpendicular to the other two, exactly at the level of the annulus. And the annulus will be displayed on my short axis view. Very easy, very straightforward. The only problem with this approach is that we are not measuring the three-dimensional structure, but we are just projecting the three-dimensional structure on a flat plane, on a two-dimensional one. And therefore, there are some inconsistencies that, of course, may occur. For example, you see here I am exactly at the level of the annulus, but here I am not, because the mitral annulus is not flat. There are heights and downs, and this cannot be accounted by any tomographic technique like what we are doing. However, it's just an approximation. Questions, doubts, comments? Stop me if I am going too fast or I'm making too many pieces of information in your brain.
Make it perpendicular.
Making perpendicular?
Yes.
Okay. So you need to go here and then to rotate it. Okay, lock slices so they are independent. Now this is perpendicular. Now this is perpendicular. Put into the center. Here we are. And now you can control the green.
This one?
Yeah. You can start from the one or the other. And now, okay. And you have your run.
That's excellent.
Perfect.
Always it should be with perpendicular.
Every orifice, you should have two longitudinal planes that are perpendicular in order to identify exactly the maximal part of the orifice, and then being able to cut it in the horizontal way. Okay? This is the basic rule. ASD, LVOT, orifice of the left atrial appendage, orifice of mitral stenosis, as we will see in a moment, all are taken in the same way. Any other question? Any doubt? Is it too much or is it okay? So, however, flexi-slice is not only to measure something, it's also for bringing you from the more complex 4D visualization when you are at the beginning of your 3D experience to a more comfortable 2D views. What I am meaning, if you click on Run, you have your data set here. If you have any doubt, for example, that here may be a prolapse of the anterior leaflet because you see that bubble, if you click on the point of the 4D image where you have the doubts, your slices will immediately reorient, and then now the yellow one and the white one are crossing the point you wanted to examine. And as you see, there is no prolapse over there. If you wanted to rotate the 4D data set, you have to rotate the short axis view in this way. Now I have my two-dimensional views that are crossing exactly the point I want to see. If I wanted to examine the lateral commissure, I click there. And now I can see the mitral valve at the lateral commissure. If I wanted to see the medial commissure, I click there. Very fast, very efficient. Is like that you are taking multiple two-dimensional views with your transesophageal probe. But here we are not doing anything else that just clicking at the different levels. So here, if I wanted to see A2, P2, A1, P1, A3, P3, I can do just clicking on the images. I don't need to make many acquisitions with the 2D echocardiography. With the advantage that using the 4D dataset, I know exactly where I am, and I know exactly the orientation of my cutting planes because I can control them.
This is as per the color of the line we are seeing the views.
Exactly. The yellow line, the longitudinal one, is the yellow view. The white line is the white view. And you can obtain as many as you want, just clicking and rotating your data set in the way you better wanted to look at them. I can obtain any inclination, whatever I want. Okay. Is it okay here? Because this probably will be the most frequently used control when you have to examine your data sets. So we can click Done. And now I have a test for you. We are looking at the valve from the atrial perspective. What we have to do to look at the valve from the ventricular perspective? Two-click crop may be an option, but before doing two-click crop, I want you to understand the concept. So the lady had a good suggestion. Great. So we have to translate the yellow line down into the ventricle and to have the valve in front of us And then, of course, we cannot see the valve because we are looking in the wrong direction. But with the flip crop, we can change our point of view. And now we can look at the valve from the ventricular perspective. So this is navigating the data set and trying to obtain from the same data set multiple information. By the way, you see how detailed is the anatomy of the leaflet with all the chordal attachment and how nicely we can see the commissure. If I go on the data set and I rotate, now I can see very nicely the lateral commissure, or I rotate the other way around to have a nice view of the medial commissure. This is really functional anatomy in our hands, and we can look at the different details just by rotating and obtaining. Okay. Yes, please. Yep. You can go on done to go out of the, okay. Now you have completely outside of the, this is probably one of the cases that you want to have for the home, and now you are there at home again, and so you can start. So don't forget this opportunity to have the for the home. The point is that you have a computer that responds a little bit slow. This is probably due to the memory because it's a small portable. So you should be a little bit patient when you click to obtain the different. So you see, I have to wait a few seconds to have a proper response. If you try to go too fast, then you have delayed response. Now I am here. I go on a flip crop, and you have the image. Okay?
Suppose I want to store this image.
If you want to store those images, just click on store. Okay?
Little creating a problem.
So what you want to do?
From the ventricular aspect, how to bring this line down?
Yes. You go here on translate. Okay. You bring in the ventricle as it has been done, and now go on flip crop, and here it is from the ventricular perspective. We have just to rotate a little bit. Okay. Let me go a little bit more down. Sorry. Now I am on the, and here you have your valve. Okay. If you want to change the layout in order to have the two, yes, change the layout like that, and here we are. Okay. Any other question about this? This work that we are doing with this data set is just to allow you to explore all the different options of EcoPack. Then this will be applied again and again and again on every data set that we will have. If you are happy, now we can also if you want to control a little bit the images. In the right lower part of the screen here, UD clarity, shading, gamma, volume optimization, smoothing, 4D clarity, all these controls just control the way you are presenting the images. The UD clarity is a sort of compression again. You can make the images more sharp or smoother according to it. That doesn't change that much in this level. The shading are the different. If you wanted to have less shades of the color, or you wanted to have the color with a larger gamma of shades. The gamma is better always to take closer to 0 to have a more compressed image. Volume optimization, more brilliant images if the volume optimization is high or darker.
Gamma?
What?
What is gamma?
Gamma is a sort of, instead of the scale of gray, is the scale of the colors depending on the map that you have chosen. And then the smoothing is if you want smoother images like this one, or more crisp images like this one, depending on your own preferences. Hey, good morning. Once we have discussed all these motion of the images and sorry, click again on 4D home, and we will go on what we will use in the clinical routine for obtaining the images that we want. It is the famous two-click crop that you have learned to use yesterday. Two-click crop does exactly what we have done when we have translated, flipped, and whatever. So you know that if we wanted to obtain the image of the valve from the ventricular perspective, for example, two-click crop, you put the cross on the images in the place you want it to be, and then you move the mouse in order to include the data set that you want. After that, you can rotate, you can navigate to improve the quality of the images. If you are careful on to the images or whatever, you will notify that the colors of the data set, despite I have the same view of before, are different with the two-click crop. The reason for that is that the colors are coding the distance, and they are normalized for the size of the data set. And with the two-click crop, we don't have the entire data set, but we have just this portion of the data set between the two lines. If I rotate my data set in this way, you will realize that of the entire data set, I have just a part. Accordingly, the color will be different. If I wanted to restore the normal colors, once I have finished with the two-click crop, I have to eliminate the parallel cropping. Parallel cropping means that all the tissue that is below this line and all the tissues that is above this line is eliminated. But now to restore that, I just click on it, and then this line will disappear, and so I have the entire data set and the colors are restored. I know that there are a lot of new pieces of information here, but just trying to give you an overview of what we can do, and in order that when you when you go home, you can play with your data set and understanding more and more. Okay, parallel crop. When you click on parallel crop, two lines appears on your screen. Here cannot be seen, but you have a line here and you have a line here. Is it true? Okay, that means that all the tissue that is above this line has been taken away, like a cut with a knife. All the tissue that is below this line has been cut away. This is the parallel cropping.
Like it's cropping in a Phillips machine. We knock off above, we knock off below.
Exactly. Good. When I eliminate the parallel cropping, this line will disappear. So all this tissue now is again available to be navigated and to be explored. Yes.
Parallel crop making this.
Yes, because now you have selected only this part of your data set. So you see only the distal part of the left atrium.
So how
If you wanted to make it larger,
large
thickness.
thickness?
If you can increase the thickness, you see,
Yes.
and now things appear inside. Is it okay? Everybody is at this level. If you are not comfortable, just ask. We can repeat again. I want you go home. We have becoming confident with these basic controls, because this will allow you to build up your experience with the 3D Echo.
Make this straight. This is a touch screen. You can manipulate with your finger.
What do you want? Yes.
The AML has gone down.
Now you are here
Okay.
and looking in this direction. So you are looking at the yes. So that's not good. You can change your point of view. For example, with the flip crop.
Okay.
And now you're looking in the other direction, but it's much better if you rotate.
How do you rotate? Okay.
When I am with this ball,
Yeah.
and let me see, you crop. Okay. When you have with this ball, and with the clicking on the left button, you can obtain a rotation. You see now I am here. If I wanted to see the valve, I go back into the atrium, and now the valve will appear. Again, you have to consider where you are and the direction you are looking at to understand what you will see in your
on the
data.
atrial side.
Yes.
I think you are on the ventricular side. So this needs to be dragged down. This line needs to.
Okay. So in this way, you can go down. Okay.
So this parallel crop can be flipped.
This is parallel cropping. Yes, this is a very large parallel cropping.
Individual line cannot be rotated or
To rotate these lines, you have to rotate the data set.
that will get bit.
Yes.
You cannot do it over here.
No, no.
But
Go
in the
on
other one you can do, no?
with the flexi slice, you can do. There you control the lines with the flexi slice. Here you have to rotate the data set because the lines give you the idea where you are. Okay? So, any other doubt or concern? Yes, please.
This EcoPack software is compatible with any vendor's data.
Say it again.
Suppose we have copied some data in Philips machine.
Yes.
Can we review and see it in EcoPack or not?
Not now, but very soon it will be possible. For now, every vendor has his own tags, and so they cannot. But there is an initiative that is under the umbrella of a joint task force by American Society of Echo and European Association of Cardiovascular Imaging that is working with the industry. And the last month in Portland, for the first time, we have seen the interchangeability of the data set. And so we hope that for next EuroEcho or latest next spring, that will be possible to use your EcoPack to also to post-process the data set by Siemens, Philips, Toshiba, or whatever. Yes?
I want to bring this down to the ventricular side.
Yes. So you can go for the two-click crop or otherwise with the translate. With the translate, you will bring it down. Okay, sorry, too much now.
Yeah, this is a good place.
Exactly. And then with the flip crop, now you have your graph.
Right, this is good.
Perfect. Any other? Yes.
Apart from speech artifact, is there any other artifact that we should be concerned of in 3D Echo?
Yes. Dropout artifacts that we have seen yesterday, and we will see again when we will look for the aortic valve or interatrial septum. And to avoid them, remember that the basic acquisition should be a little overgain about that. Then we will have some static artifacts that let me do like this. At the end of the morning, if Dr. Gupta will allow me, I will spend 20 minutes to show you the different artifacts and how to, I have a presentation for that. Because it's easier if I show you than trying to explain. Okay. Are you ready for the next level? Okay. The next level is quantitation. So, if we have this nice mitral valve, we can try to measure, and now measure 3D. Go and select the folder measure. And go down to find a folder that is called the valve here. And among valve, select 4D Auto MVQ. Few seconds that the software starts. Okay, here we are. If you remember yesterday when I have shown you the quantitation of the left atrium, I told you that there is, with any quantification software, there is a usual workflow. First of all, we should align the data set. Then we should initialize the data set. And after that, the software will detect automatically all the borders. Orienting the data set means that we should tell the software what is high, what is low, what is left, what is right. And to do that, we will follow the indications that are in those miniatures here. To do that, we have the usual functions of our pointer. If I move the pointer out inside of the data set, it will become a double arrowed cross. That means I can translate up and down, left and right. If I move outside of the images, it will become a circle, and then I will tilt clockwise or counterclockwise. By doing that quite carefully, I should be able to obtain the views as indicated. Here I will have a bicommissural view, the line a little bit up, and then I will rotate the longitudinal view in order to have it oriented in the proper way like this. Also the lines can be rotated this time and positioned in the proper way, like this. Then it's important that the valve is in the center of the aorta in order to be able to see the aortic annulus at this level. By doing it quite carefully, at the end you should obtain an image like this one. So proper bicommissural view at this level, long axis view with the aorta here, and the axis, the green and the white, that crosses in the center of the mitral valve and the aorta. Are you with me? Yes. Very good. Now, the difficult part is finished. Now you can go at the second level, that is the data set initialization with set landmarks, and click on that. Now, when you move your pointer into the images, it's automatically selected the points that you are going to check. Mitral annulus 1, not at the hinge point of the leaflet, but well inside of the annulus. Click with the left button. Mitral annulus 2, on the same images in the annulus, click again. P is a posterior annulus in the apical long axis. A is the anterior annulus here on the mitral aortic curtain. And then there is coapt, the coaptation point of the two leaflets in the long axis. And finally is the aorta that goes to the insertion of the right cusp of the aorta into the aortic annulus. Done? Perfect. Click here, and now the system will take care of reconstructing the mitral valve for you. Here we have the mitral valve. You can go on this surface rendering of the mitral valve. This way of displaying the images is called the surface rendering. It's just a mapping of the endocardium. If you go and click with the left button of your mouse, you can rotate and look at the shape of your mitral valve. The yellow circle is the aortic annulus. But we can also check the accuracy of the mapping of the software. Usually in a functional mitral regurgitation, is it quite accurate? The automatic detection doesn't require any major editing. This will be much more demanding when we have flail or degenerative mitral regurgitation. However, okay. So we have to rotate a little bit in order to have it horizontal like that. And also rotate this one.
Here the image has to be rotated.
Yes, we rotate the images in order to replace this. And then we will have this. Okay. You see, now you have a proper bicommissural view over here, the long axis view. What you have to do now is to put the cross in the center of the aorta, like this. Now we have the proper orientation of the data set. Okay? Yeah.
This green line is not at the center.
The green line, no, is not in the center. You have to go back a little bit to align views. Okay, because this one should be rotated a little bit. No, first this one should be horizontal. Then you have this one that goes up a little bit in order to cross the base, and this one is now. Okay, now is in the center. Okay, we needed to follow carefully the orientation of the data set, otherwise we don't have the proper reference. The most critical part of all these is the first one in the orientation of the data set. If you spend 1 minute more there, then the software goes quite smoothly. So how we can edit the leaflets if needed? Because we can move these vertical lines. For example, the green one is green, so it controls what we see in the green panel. I can move it all along the commissure to check from one side to the other the accuracy of the leaflet mapping made by the computer. If I needed to change anything, and in this case I don't need, it's very easy, because just I go on the image with my pointer, I click on the part of the image I want to change, and just I drag the image where I wanted to see the new line. Very easy, very straightforward. And I can do it all along the commissure, or I can scan anteroposteriorly like that. You see? It's very efficient and very nice. We will see much more with the degenerative mitral regurgitation. When I have made all the changes that I need, I go directly to results, And now I have the final model. The final model is colored, and there is a meaning in the colors. Green is everything is at the level of the annulus. Blue is everything that is displayed towards the ventricle. Red, everything that is displayed towards the atrium. We have a lot of parameters that have been measured here. The annulus area, the perimeter, anteroposterior diameter, posteromedial anterolateral diameter, intertrigonal distance, annulus height, and so and so. If you have any doubt of what those measures mean, just click on them, like anteroposterior diameter, and the measure will be shown on the model. These measures are just a synthetic report of all the measurements that have been done in the background, and the complete list of them can be seen by clicking on annulus or leaflets. You see how many parameters have been obtained with just a couple of clicks. Sorry, I cannot hear you. Yes, green is all the tissue that is at the level of the annulus. Blue, all the tissue that is displaced towards the ventricle, tenting, tethering of the leaflets. Red, everything that is displaced in the atrium, prolapse, flail. We will see in a moment. Here we have a lot of blue because there is a functional mitral regurgitation. The tenting volume is 8.5 milliliters, and so there is a tethering of the leaflets towards the ventricle.
My colors are different from yours.
Your colors are different from mine? No, they are not. They are absolutely identical. Now I have different colors because I have clicked on to show the intertrigonal distance. But if now the colors are exactly the same. The software is very, very robust. The only thing you have to pay real attention is in the orientations of the view in the first step. We will see again, because now I am going to show a case of degenerative mitral regurgitation, if you are interested in. If you have questions or comments.
So this measurement can be used for mitral clip?
Can be used for mitral clip, can be used by the cardiac surgeon when they are dealing with a patient with functional mitral regurgitation, have to decide if they wanted to go for a restrictive annuloplasty or they have to replace the valve. Because with the annulus height of 0.5 milliliters and a tenting height of 1.5 centimeters and a tenting volume of 9 milliliters, this patient is not suitable for restrictive annuloplasty unless they are able to do an extension of the leaflet, but it's very complicated. Probably this patient, if considered for surgery, should have replaced the valve. Then can be used for mitral clips as well, and everything. Okay.
There are so many measurements. Will the surgeons be able to?
Yes, there are too many. That's absolutely true. But you know, the engineers, when they have something to measure, they are really excited. We were able just to obtain this summary in the worksheet. the important measurements, really important measurements, are the annulus area, the intertrigonal distance, that is where they size the prosthesis, the annulus height, that gives you an idea of the flattening of the annulus in functional mitral regurgitation. As we said before, the tenting height and the tenting volume, that is not reported here. And in patients with degenerative mitral regurgitation, the mitral aortic angle is very important, because when it is a very narrow angle, there is a risk of SAM after surgery. So those are the measurements that are more important from that. But then you have everything. For example, for scientific purposes, it's very important if you want, for example, in mitral clip patients, to study how the perimeter of the mitral annulus can affect the results of a mitral clip, of how it changes the area of the leaflets, blah, blah, blah. These are all available here. Okay. Very, very good. Now we can go back on archive and select a patient with mitral regurgitation organic, TOE 3D. And here we have our patient with, okay, 26, perfect. Oh, the first one, but I think that they are quite 3D, PD 2 underscore 2 TOE. This one. Got it? Then you have two data sets. I would say, let me see the second one, which is again 26. You can take each one you want. Take the second one, so we have also part of the left atrial appendage. Hey, good morning. Good morning. So the second data set. Are you in trouble? Okay. Everybody is with the data set? Perfect. So any suggestion how we can improve the way these images is displayed? The AV should be on top. I think it is. Just the appearance of the image. It's not negligible the way we show the images and how they are stored on our archive. Because this is your business card. No one in my hospital knows Luigi Badano. They don't care. But everyone can see the images we produce on the system. And so if we produce garbage, they think that Luigi Badano is a very bad echocardiographer. But if we polish the images, present nice images, this is our business card. Say, wow, this is really cool. It should be so good as an echocardiographer. Then I don't know anything echocardiographer, but I'm just making very nice images. Because this is what they see. So we have the HD live, we have the proper images And this is a case of degenerative mitral regurgitation. Any comment about the anatomy? It's not a normal. Yeah. Flail of 8 to 2. Okay. I don't agree, to be honest. How we can check?
Aorta is at 12 o'clock, so AMM is
This is the aorta. What is this structure? The appendage. This, what is this structure? This one, what is? No, this one. The interatrial septum. Okay. So, here we have P1, here we have P2, and here we have P3. We have something wrong, I would say, in P2. And there is, it's not a cleft because it doesn't arrive to the annulus, but it's an indentation, I would say. That is the usual way we distinguish between the two. Remember yesterday I told you if you are not so confident with the 4D images, just reduce the speed the images are playing. It's easier to appreciate the anatomy. And when you have got a precise idea, then play them again at the right speed. This will allow you to become more confident with those images. Then still we are in doubt. So how can I check if it is really a P2 problem? Flexi slice, very good, because with the flexi slice, as we discussed yesterday, will bring you at your bed and butter, that is 2D images, where you are really confident with them. I place my cross on the structure I wanted to examine, and here I have the proper 2D image. Now there is no doubt of which one is the anterior or posterior problem. Flexi slice is the one you will use more and more during your clinical practice when you are in trouble. Then, still, I am not fully happy on your diagnostics of this mitral valve. Tell me more. Are the leaflets normal? Remember the leaflets we have seen before, very smooth, very nice. Are these similar? There are bubbles everywhere. It seems that everything is prolapsing.
the amount of valve tissue in the AMM is very less. Is it normal?
The amount of tissue?
In the AML, anterior mitral.
Because you are tricked by this flail. But indeed, there is a very well represented posterior leaflet. So, this is the typical characteristics of the Barlow disease, particularly if this patient is a young one. And another characteristic that differentiates the Barlow disease from the fibroelastic deficiency is the multiple area of prolapse we have seen, but there is another very important, is the size of the annulus. Usually Barlow has a huge annulus. Fibroelastic deficiency, the annulus is normal or only mildly dilated. And we will see the quantitation. And finally, there is something more that we can notice. It is also the number of chordae that are ruptured that we can see here very nicely. Again, if you wanted to see the anatomy in detail, you can also change the maps, the color maps, try with the anatomical one, and you see that now details like the rupture cord are more evident. It's not nice to see, but it's very effective to look at the details of the anatomy. And then when you are ready, you can always come back to your copper blue that shows the proper anatomy here.
Is there a depth guide? Like the way we have a color,
Sorry?
the way we have a color guide, you know, when
Yes.
velocities. Is there a depth guide? I mean, like how far
No.
you are looking at?
No, unfortunately not. Unfortunately not. Or I'm not aware of that. So now if we are ready, we can go for the quantitation. And as you know, as we have done before, we go for measure. We find the valve folder. And in the valve folder, we will select, we will select the auto MVQ, mitral valve quantitation. Again, the usual display. We follow the dataset orientation that we have there. The bicommissural view should be horizontal. Move the yellow line a little above the mitral annulus. And now take care of the longitudinal view and of the orientation of the yellow and the white line in this way. This is the most important part in your quantitation. Finally, don't forget also the unfazed view here, where the two lines should be in the center of the valve, passing through the center of the aorta, here. So at the end of the day, we will have a bicommissural view here, correct longitudinal view with a well-symmetric aortic root, and here in the center. Take care of this step, because this will make everything ready. So now we initialize the data set with the set landmarks. This is easy. We go, remember to be generous, so not at the hinge point of the leaflet, but well in the annulus. Mitral annulus 1, 2, the posterior leaflet, the anterior leaflet, the coaptation. Here in this case is difficult because we have a flail, but that's the presumable coaptation point, and then the attachment of the right coronary cusp to the aortic root, like this. You have the immediate quantitation of the annulus and the first display of your mitral valve that you can rotate and look at. Here is difficult. It's a difficult task for the software. And as I discussed yesterday, despite the software in 3D are independent on any shape assumption, Still, some assumptions should be done, otherwise you cannot reconstruct the model. And the basic assumption in the mitral valve is that the leaflets close and collapse. That is not the case in the flail. So here is where we have to edit. And you see, for example, in this position, the software didn't detected the flail leaflet because it's looking for the cooptation. We needed to tell the software that here is a flail. So first of all, we will tell the software that there is no cooptation. So we move the pointer where the cooptation is and click on one on the arrows. Now the two leaflets are independently controlled. As we have seen before, it's just enough that I click on one point and I can change the way the leaflet is shown, like this. What? Just clicking on the arrow. Yes, single click on the arrow, so when you click on the cooptation point. And then, since it's a degenerative change, I have to look at it all along the commissure. So I will move the green line in the different positions in order to edit point by point my leaflets. Here they are okay. Then I go in this direction. Okay. And if I look at my model, it's changed a lot. Now it's showing the flail. Are you able to do that? Okay. When you finished, you can click on results. And now, as we discussed yesterday, there is no more blue, but there is just the red and the orange part where the flail has occurred. And the model shows the regurgitant orifice.
The question is, in which phase we should utilize this? In opening of the mitral valve timings or
Mid-systole, when it's closed.
when it's closed?
Mid-systole.
Mid-systole.
But the software automatically selects for you mid-systole. And you can change the frame as usual, but you have already automatically selected the valve, the closed valve. And then we will have all the quantitative assessment as we have seen before. Do I need to revise the measurements? Okay, so here we have the worksheet where is a summary of the most important measurements. The 3D annulus area, the perimeter, anteroposterior diameter, posteromedial anterolateral, intertrigonal distance, the annulus height, that means how the saddle shape height, the mitral aortic angle. If you have any doubt about what those measure means, just click on one of them, like the mitral aortic angle, and then this will be shown on your model. But if you wanted to have the extensive measurements, go to the specific folder, the annulus. For example, remember what I said before, about measuring the annulus using the flexis lines, that is a projection of the true annulus on a flat plane. This is shown here. You see the difference in area between the true annulus area by 3D and when you project those complex three-dimensional area on a flat plane that is smaller, of course. And then on the other folder, you have all the possible measurements about the leaflets. And again, even here, if you needed some clarification about the area of the leaflets or whatever, just click on them and this will be shown on your model. The last one, the orifice, yes, I would not rely on that because depending on how much you displace, that is shown, but this, I think it's not reliable.
Cost is 2.6 square feet.
Yes, depends if you consider more the core. No, this one is really the only one that is completely unreliable. It's just the engineers that. No, it's always unreliable. No, orifice area, forget it. Forget. Because it's depending on our editing. So that's probably everyone in this room has a completely different orifice area. So this is what I know about the mitral valve, the way of looking at the valve display and quantitative assessment. I don't know, okay, Dr. Gupta is not here, okay. Just to finish the mitral valve, if you are interested in mitral stenosis. So we select from the archive another patient. Oh gosh, I don't have.
Next, what would you like to have ASD?
I was aiming for mitral stenosis, but we can go for ASD. Or you want to have a patient just to have a break, or you prefer we go on or to see a patient? Go on. ASD. Yes. It's for the aortic valve, but it's only for the LVOT. It's not to quantitate the aortic valve itself. It's just made to have an automatic quantitation of the LVOT size.
For like tower prosthesis.
For tower prosthesis.
I thought it's like for mitral valve, it's like for aortic.
No, not yet. Not yet. The only company that has developed a dedicated software for the aortic valve is Siemens. They have a dedicated one. Okay, ASD, dataset number 13. Okay. Do you have this? Okay. So now we can translate our cut plane order with the 2-click crop to look at the ASD from the atrial side. And as we have seen yesterday, when you have an ASD, just to show it in a proper orientation, the most important anatomical landmark is the aorta. This is the aortic root, and this is the aortic cusp. So that means that we should always have a piece of the aorta in our acquisition, otherwise we lose the possibility to orient the data set. When we have the aorta, we know that the anatomical orientation, that is the one that will be followed also in the cath lab, is the one with the aorta on the right side. The superior vena cava here, you can rotate to look at the orifice, and the inferior vena cava over here. Sorry? Here is our ASD. How we can quantitate the ASD? Flexi slice. It's an orifice. So everything can be done in this way. So to make the quantitation, we go on the flexi slice. Yes. We stop the image where we see better the orifice. Select the frame where it is larger, like that, and now we are ready. What I have to do? Move the vertical lines. Here I don't see the orifice, just because my white line is not crossing the hole. So I will move the white line, rotating it to have it perpendicular, just away from lock, and move it into the orifice. As soon as I have the line into the orifice will appear also in the other one. Also, there is an advantage, because this one is the bicaval view, superior vena cava, inferior vena cava. So this is the superior rim, this is the inferior rim, that is quite small. Here I have the aorta, so this will be the anterior, and this, of course, will be the posterior. And I can eventually measure. Then I move the yellow line also into the orifice, and now I have the orifice perfectly aligned. Superior, inferior, anterior, almost not existent, and posterior rim over here. Sorry?
Bicameral view at top, we see the IVC. As the IVC.
The IVC should be here. but it's very low, the position of this ASD, so the inferior is very small. Now I have just to move the green one at the level of the orifice, like this. Orient perpendicular to the axis, as we have seen before. And here is my ASD that I can eventually quantitate. To quantitate is better to enlarge the view using our layout until I have the proper view. Sorry. And here is the orifice. I can easily planimeter, as we have seen before. How I know that the orifice is this one and not this one? Because the lines are in this one. And why I have an orifice here? Yeah, because if you follow the green line, you see that here there is a movement of the septum above the line, and the line is a two-dimensional view, so just sees what is crossing, and here is crossing the empty that is behind the true septum. So we are learning also some of the tricks of two-dimensional echocardiography by looking at the true anatomy by 3D. And we realize how images are built up. So here, this is the hole because the lines are crossing this one, and this is just not an artifact, but it's a false image due to the motion of the interatrial septum. Layout, make the planimetry, and this is done. Yes, please.
We are measuring by planimetry the DST in one dimension here. But how can we measure in other dimensions?
Which dimension you want?
Like suppose the part which we have seen in by planimetry.
So what I can do here, let me try to answer your question, is first to make the diameters if I wanted to realize the shape, or to make the trace of the borders. Okay, sorry, I don't have so it's not precise, but like this. And so I will have the area, the circumference, and the length, the major, the minor, or any one I want. This is what you need. Plus all the rims that we have seen before. Yes, it's in a different place. I have just to go find the hole. Of course, the acquisition should be with the hole inside of the data set, and then I can do everyone. We have a lot of sinus venosus that are very difficult to see with conventional transesophageal, but if you acquire the data set and then you are able to crop, they are very nicely seen.
If we measure or if we planimeter without using plexus slides,
Yeah.
how much is the difference?
Probably is not that much, because the interatrial septal defect is quite a flat structure. So you don't have that much discrepancy in the depth, and you see that the colors are almost uniform on the borders. So I don't think that there is that much. but I have never systematically tried. But in this case, probably you don't have a big difference.
But we should always measure after using the flexi slice.
Yes, one reason for that is not because of the difference, but because of that. Look here. Look at the screen. I can have a huge, okay, this is too huge dia, or a very small dia. And what I have done, I am just changing the 2D gain. This doesn't change so much on the flexi slice. The volume rendering is extremely sensitive to the gain regulations. Not that much when you obtain the slices. This is why we still prefer to have a quantitation of the orifices using the flexi slice. Okay. Very good.
What do we exactly mean for the terminology of surface rendering and volume rendering?
The terminology is like that. Let me go back to the mitral valve. That is probably. This is volume rendering. So it gives you the anatomical display of the structures. Differently from the surface rendering, that is what we obtained after the initialization of after the quantitation. Let me go quite fast here. Okay. Okay. Here you see that you don't have any anatomical detail. What the software does is just a mapping on the endocardial surface. So the first one is for anatomy. This one is for quantitation. This is done for the cavities, right ventricle, left atrium, and is done for the valves as well. Just a mapping of the endocardial surface for quantitative purposes. No anatomy is shown here. Okay. I have the mitral stenosis. So instead of PD in last name, please type mitral stenosis. And you have the data set mitral stenosis TE. Click on that. And here we are. Take the data set number 23. As you see, also in transesophageal echocardiography, we will use very much the multi-slice display during the acquisition to be sure that every part of the structure that we would like to have is included into the data set. And in this case, the mitral valve and a part of the aorta and a part of the subvalvular apparatus. to move from the multi-slice displays to the volume rendering, how can I do that? This is for you to have practice of the software. Done. Click on done. And now you have your data set. Here I am outside of the data set as a point of view. You see where I am sitting. So I see the uncropped data set. The uncropped data set is just a pyramid of data with it's meaningless until we start cropping and navigating. If we are in trouble, we have always our 4D home button where we are. Now we wanted to see the mitral valve from, the stenotic mitral valve. And to see the stenotic mitral valve, which is the best view I can use? Flexi slice, okay. Where I put the cross? In LA? Oh no, flexi slice, sorry. Two-click crop. Where I put the cross? LV, because LA is useful for degenerative mitral regurgitation, but here I have to look at the commissure, I have to look at the restrictive orifices. So this is the case where I will use the ventricular perspective of the valve. I click here and I go in this direction. Uh-oh, what a bad image. I don't see anything. 2D gain. Very good. Sorry. I have too much gain here. So I have to polish my images. And now the anatomy comes out. Still, I am not that happy with this image, because it doesn't seem that is oriented in the proper way. What? Okay, we have to rotate in which direction? Anti-clockwise, very good. What about this? Now it's better. How can I make it even better? HD Live, very good. Zoom is another very good option to see it a little bit larger. Okay. Now I think we have a reasonable view of the mitral stenosis. And we have the way to look at the commissure. Here I am looking at the lateral commissure. I can rotate more to see the extension of the fusion, or I can rotate my data set to look better at the medial commissure. And probably I should go a little bit closer in order not to have other structures that obstruct my view. I see very nicely the doming of the valve. And what is the pseudo prolapse of the anterior leaflet with the valve is closed? What is here? What is here? Left ventricular outflow, and eventually I can rotate the data set to see the aortic valve in the background. over there. So this is really anatomy that I can study and I can navigate to look at the different parts. We have discussed yesterday about two limitations of 3D echo in mitral stenosis. The first one is don't judge the thickness of the leaflets, cord or whatever, because of the reduced spatial resolution, they appear thicker than they actually are, so much better 2D for that. And don't use it to judge if there is any calcification or not, because the color, once again, has nothing to do to the tissue characterization. It's just coding the distance. And then, once more, when we are when we have to quantitate, we will use our well-known flexi slice. We will stop the image when the valve is properly open. Okay. Then I see the orifice here, but I don't see it in this orthogonal view, simply because this is the white one and the white axis is not in the orifice. I have to move it into the orifice to see the orifice also in the other one. And then I will reorient my yellow one again into the orifice over there, and now I have the nicely displayed orifice. I have just to move the green one to the tip of the leaflets like that, and now I have perfectly depicted the residual orifice, the narrowest. I know where I am, and the orientation of my cut plane is not anymore dependent on the view, but is anatomically sound because I have oriented in the proper way. You can notice, and you probably well know, that the axis of the opening of the mitral stenosis is never parallel to the longitudinal axis of the left ventricle, but it's always skewed, and particularly skewed towards the lateral wall. So when we make the planimetry of the mitral orifice on the conventional short axis view, the perfect short axis view is perpendicular to the long axis of the left ventricle. That means that the mitral valve is cut in this way, like a salami. We always overestimate the true size of the residual orifice. And this is particularly a problem when there has been a valvuloplasty in the cath lab, and we have to judge about the effectiveness of the procedure. In this way, we have a anatomically guided quantitation of the orifice. And once again, I will, using layout, I will expand my view, and now I can make a simple planimetry of the orifice. Questions? Comments? Sorry?
Measure.
Yes, you go on measure, and then select the area trace. Sorry. Comments, questions, doubts, coffee? Sorry?
This method should be more closer to the reality.
Yes. By the way, this is now the reference, the standard for the mitral valve area. The method that is closer to the Gorlin invasive quantitation. There are a couple of papers. They are quite old because they are from 2004, 2006. Pepe Zamorano, Roberto Lang, that have validated the method. And now in the guidelines, this is the method of reference.
So as we do believe this score for mitral valve before doing a balloon mitral valvotomy, to look for the chordae, other things, those things are not feasible with 3D because of, as we said, the thickness increases.
So there is a paper. The first name is Anwar. Has been published a few years ago, and recently he has also made a validation with the scoring using 3D. So you can find that. Interestingly, no one else has ever used that for the reason I told you. You are overestimating the thickness and you are overlooking for the calcifications. So still, I think that for the Wilkins score, we have to rely on a 2D. Okay.
When doing the echo, we measure the mitral area by 2D as well. So we should mention separately that this is by 2D and this is by 3D.
Yes. This, indeed, you touched a very important problem. Also, when we make the quantitative assessment of ventricular volumes, ejection fraction, and you know that with the 3D, volumes are larger, and particularly in patients with extensive wall motion abnormalities, ejection fraction can be either lower or higher than assessed by 2D. And the problem when for many years you have followed a patient with the 2D, now suddenly volumes changes, ejection fraction changes, or area changes, you may confuse the referring physician. So what we do, we have tried several attempts. The first one was to provide both 2D and 3D measurements. But then the feedback we had is, so what? Which one I have to take into account? You cannot give me two and I have to choose. Give me what it is, the measurements. So what we do now is to provide the 3D measurements because are the most reliable. And if there is a significant change compared with the 2D, we had to our report a comment. The new measurements have been taken with using 3D echocardiography, and the changes that you see are due to the use of this technology and not to the actual change in the patient condition, or it has been a real change in the patient condition if it is true. But we compare the old 2D but provide the 3D because we are trying to complete the transition to the 3D assessment.
But you haven't stopped measuring by 2D.
No, we don't. We don't use 3D for every patient. Normal patients, hypertensive patients, patients who come because they need a non-cardiac surgery and so they need an echo. We don't lose time in acquiring 3D. Also because 3D datasets are very heavy.
For MS cases, every cases of MS, you do 3D?
For image cases, what?
MS, mitral stenosis.
Yes. Mitral valve disease, always 3D. Left ventricular dysfunction, either cardiomyopathy or ischemic heart disease, always 3D. Patients with monitoring cardiotoxicity, always 3D because ejection fraction is more reproducible, and so we will say the ejection fraction is changed by 5 point percentage, we are confident that this is true and not just a mistake in measurements. All patients where the right ventricular volumes and ejection fraction are an issue, those are goes for 3D. Just what we say, useless echo, we don't acquire 3D. Any other? So now I will drink a little of water. If you so probably now I have shown you almost everything I know about these 3D, except the quantitations of the ventricles. Are you interested in that? But to do that, we need data sets. I don't know if you have on your, let me see. Oof. No, I don't see. Let us see if we can acquire a patient and while we are acquiring a patient, there is, where are the technicians of GE? Okay, I will give you a pen if you can upload a data set. And from that one we can okay. There is a pen here, a data set here called Byzantine that you can upload, and we will have Dr. Gupta is here because do we have the patient because probably he needs some time for with this data set we will be able to see the quantitation of the left ventricle, the quantitation of the right ventricle, and eventually of the left atrium. And so we will complete all the quantitation package. So, which is your impression? Is it complicated?
No.
Probably not that much when you know what to do and how to do. What is my recommendation is try yourself. Don't lose what we have done in today, because then you forget all the buttons and tools. So if you tomorrow you are in your practice, you can try to do some mitral valve, try to do some ventricle, try to rotate the data set, so and you will become more and more confident. Yes, this one. Thank you. unfortunately, but also it's quite interesting that young fellows are much more enthusiastic to learn 3D than conventional echo, because having the opportunity to look at these anatomically sound images for them is much more easy than to look at the 2D slices, and much more exciting. For us that we have grown with the flat mind of 2D and M mode, it's difficult to make the step forward in this huge 3D world. But for someone that has a clean mind, it's very, very easy.
We have to unlearn 3D. We have to unlearn 3D.
You have to unlearn
It
two
will be.
Yes.
Now we relearning.
Yes. This is the good of medicine. You know, you never stop learning. Every single day we learn something from patients, from fellows, from something.
Industry partners.
Yeah. This is the good and the bad of this, but we need also on their computer. The good and the bad of our profession. Okay, a few moments that we will provide you the data sets. What is really important is that you pay attention to the acquisition. The acquisition is absolutely crucial. And now I will revise with you what we have discussed yesterday, to the fact that you cannot make a single acquisition and having everything. We are not at that level with the technology. We have to have dedicated acquisition for the left ventricle, dedicated acquisition for the right ventricle, dedicated acquisition for the mitral valve and the atrium, to optimize the things. We can, while he is uploading, we can discuss these points. Okay. This is an acquisition for the left ventricle. As you see, we have cut away part of the left atrium in order to reduce the traveling distance and the time for the ultrasounds. We use this multi-slice display in order to be sure that the entire crown of the myocardium is inside of the dataset in any direction, and to check that there is no stitching artifacts. Here we have a very good temporal resolution that is 32, and it's okay. The minimum temporal resolution that we should have for quantitating the ventricles is 20. Less than 20, you are at risk of losing the end systolic frame, and so underestimating the ejection fraction. When we show this multi-slice display, we can also interact on the way it is displayed by repositioning the most basal slice, that is this white dotted line that controls the position of this particular slice, white, white, and the position of the yellow dotted line, yellow, yellow, that is the most apical. So I can reposition them not only in terms of a level of the ventricle where they are, but also changing the orientation in order to obtain true short axis view of the left ventricle, independent on the way we have acquired the left ventricle. And there is something more that I can do with the 3D echo. You see the basal slice of the left ventricle, the short axis view. One of the problems with the 2D echocardiography is that when we look at the thickening of the ventricular myocardium, this is not the true thickening, because the myocardium that this line crosses in diastole is not the same that is crossed in systole due to the shortening of the left ventricle. So we judge this as a thickening of the left ventricle, of the myocardium, sorry, but it's not the same myocardium we see in diastole and in systole. With the 3D echo, I can overcome this problem with the where is the where is the dynamic? Why I don't have the dynamic? Oh, why I don't have the dynamic here? I will come in a moment. So multi-slice again. Okay, there should be the dynamic mode, but now.
I think that is the translation.
No. There is a way to anchor the slice to the muscle that is called dynamic, but I don't see anymore. I don't know why. GE representatives, where is the dynamic? It's in your laptop. So if you click on dynamic, you will see that this is anchored to the myocardium and it moves according to the so it's the same myocardium that is crossed throughout the cardiac cycle. This is an important point. So what I was saying, that I can control the position of the most apical, I can control the position of the most basal, and the other 7 are automatically repositioned in order to have equidistant slices in between these two. Of course, if I needed to be more detailed in a point of the myocardium, for example, let me say that there is a case of apical non-compaction, I can concentrate all my slices in a particular region of the ventricle in order to have all the slices looking in very detail at that particular region. So masses or abnormalities of the wall can be looked at very detailed in all the circumference of the ventricle. Then this slicing mode can be customized according to your needs. Now we have selected the 12 slice, but we can have just 9 slices, only the short axis. We can have a reduced number of long axes, 3 and 4, up to 5. This is just according to your need and preferences. We usually have by default the 12 slices because this allows to obtain a complete overview of the ventricle. Okay, what I can say more? Just waiting for the upload of the data set. Or Rakesh, if you have patience. Okay, so we go on with this.
Very useful session. Good for a mitral valve, good for LM and AJ chapter defect. Volume modification. They be suggesting also volume modification. We could get a patient on VSD possibly.
But it's the same, like ASD. It's always the same. So you use the 2-click crop to be in a face view and the flexi slice to quantitate.
Yes, your common artifacts.
What?
Artifacts.
Heart defects.
Artifacts.
Artifacts. Yes, I have to.
Like some tea or coffee.
No, I am fine with the water. Okay. Thank you. Let me do like that.
Meanwhile, we are setting up, you can have a break profile, cold tea, coffee, fill up yourself or empty yourself.
I need some power. Yes. Yeah, we have to connect to this one. Yes, we connect this one. I will show a few slides and then do.
One signature, one person is leaving right now.
Ah, okay.
So,
Thank you.
thank you. I will take photograph, light on. Come in here. I'm sorry, one more is leaving. The two people are leaving that.
Two.
Yeah, this is already
Okay.
done.